So today we're going to be discussing about mental health and the role of the pharmacist in mental health. So let me do the honors of introducing our guest today, the one who will be taking us through this whole topic. Her name is Kudzai Daisy Kawenga, who is a consultant at DATIS at the UZ. Daisy obtained her Bachelor of Pharmacy degrees from Rhodes University in 2021, and she managed to complete a Master of Science in Medicine and Clinical Pharmacy. Pardon my pronunciation, but it's Sefako Magato Health Science University in 2024. She has also worked as a clinical pharmacist in South Africa, and her main professional interests lie in psychiatric pharmacy, with a particular focus on the optimization of pharmacotherapy and the integration of mental health services into our primary care. So, without wasting much time, I'll give her to take over. I think we're in good hands, as you have seen that her interest lies in mental health. So, Miss Daisy, you can continue.
Thank you so much, Lauren. Thank you for this opportunity. Hi, everyone. I'm not sure if you can see my screen, but can you just confirm with me whether you can see the screen, my presentation slide? Not sure. Okay, now it's fine. They can see. Perfect. Okay, so thank you everyone for having me. As already mentioned, I am a fellow pharmacist with a passion for mental health and how we can effectively integrate stable mental health systems in low resource settings. And so today we'll be looking at mental health in Zimbabwe. I'll be discussing some of the challenges, opportunities, and the role that pharmacists can play within the mental health paradigm. And so, just an overview of today's session. I'll start by introducing the topic to you, and then I will head into some of the global mental health pharmacy practices, the barriers that are found in low resource settings such as Zimbabwe, some lessons and adaptable strategies, and capacity building for pharmacy professionals, and some case studies that can help us put things into perspective. And then I will conclude this session. Okay, so on the 10th of October, we celebrated World Mental Health Day, and this year's theme was access to services, mental health in catastrophes and emergencies. So, this is an annual event which seeks to promote education on mental health, to challenge stigma, advocate for stronger policies and services that can support the mental health of everyone. What I also love about this day is that it offers an intentional moment for individuals around the world to share their stories, to speak openly about their experiences, and to remind others that mental health is a universal aspect of human life. And over the years, we've come to understand that mental health is not a separate or isolated concept, nor is it only relevant to those living with mental health disorders such as schizophrenia, bipolar disorder, or major depressive disorder, and so forth. But rather, it is deeply intertwined with every part of our daily lives, from our relationships and our work to our physical health, environment, and even down to our sense of purpose. And so recognizing this then helps us to build more compassionate communities, and it reinforces the idea that caring for our mental health is just as important as caring for our physical health. Now, a clear example of this was during the COVID-19 pandemic. This was a period that was marked by lockdowns, social isolation, economic strain, and uncertainty, which are like the four horsemen of a mental health breakdown. And many individuals experienced this. They experienced anxiety, they experienced grief, they experienced distress, and yet access to mental health services was often limited or disrupted. And something that was quite noteworthy about that period was that pharmacists were classified as essential services, meaning that most remained open even when many other sectors were forced to close. So, this not only ensured continued access to medicines and health advice, but it also highlighted the critical role that pharmacists play as accessible frontline healthcare workers. We are often the first point of access to the healthcare system. And so, while hospitals were overwhelmed and many clinics had limited operations during that time, pharmacists became one of the few consistent points of contact for people seeking medical guidance and reassurance and support, especially community pharmacists. For myself, during lockdown, I was working at a retail pharmacy, and there were times where some patients would come, and not because they needed medication or to get their blood pressure taken or even to measure their blood sugar levels, but because they needed that human connection, they needed that reassurance. And I often joke about this, but and perhaps my fellow pharmacists can relate, but in many ways, we are people's unpaid therapists. When I think about it, most patient interactions, they usually begin with that brief 5-minute exchange that's focused on gathering your patient information and dispensing medication. And then it often then evolves into something deeper. There's that extra 10 or 15 minutes that is filled with those heartfelt conversations about life and family and faith, and these moments, though seemingly small, they speak volumes about the trust that people place in us and the vital role that we play in supporting not only their physical well-being, but their mental well-being. And so today I want to put all of this into perspective for us. So let's start with the numbers. Recent data from the World Health Organization shows that there are more than 1 billion people living with mental health disorders. They represent the second biggest reason for long-term disability, contributing to loss of a healthy life. And there's something even more concerning about this, in that over 75 of those affected live in low to middle income countries. And yet, most African countries allocate less than 1% of their total health budgets to mental health services. And so, this lack of investment often leads to compromised care and, in some cases, even human rights violations. Mental illness in Africa has often been described as a silent pandemic. And to give you a sense of scale, there's on average one psychiatrist for every 1.5 million people. And so that's one specialist for an entire city or even a province worth of individuals who may need mental health care. Now, the challenges also go beyond the numbers. There are some structural and systemic barriers, such as inadequate infrastructure, a shortage of mental health professionals, stigma, and limited access to care at all levels that continue to widen the treatment gap. But despite this grim picture that I have depicted, there is a silver lining. There is a growing movement towards solutions that are both practical and sustainable. And one of these is the integration of mental health into primary health care. And this approach has been recognized as the most effective way to bridge the treatment gap. And it now forms the foundation of many health policies in Africa. Primary healthcare teams are increasingly being trained and empowered to detect, manage, and to provide long-term support to individuals living with mental health disorders. And within these teams, there is a group of professionals who are uniquely positioned to make a real difference. Pharmacists. Okay, so now that we have painted the global picture, what does the picture look like in Zimbabwe? So Zimbabwe is a lower middle income country in Southern Africa, and it faces the same socioeconomic challenges that most African countries do, such as high poverty rates and economic instability. And it's these factors that put a strain on its healthcare system. which then also impacts its ability to provide comprehensive mental health care. According to data from the World Health Organization's 2022 investment case, depressive disorders affect an estimated 4% of the total population, and a growing body of evidence suggests that the true prevalence may be even higher. Studies in primary care settings have found rates of depression as high as 60%. Anxiety disorders affect 2.8% of the population and account for 4% of all years lived with disability in the country. This aligns with the global trends where the disease burden has shifted from your communicable diseases to non-communicable diseases like mental health conditions, and from premature death years lived with disability. Major depressive disorder in particular has risen significantly as a leading cause of disability globally. And certain demographics are very much affected. So you have your young adults, those ranging from 20 to 29 years, that show higher rates of bipolar disorder, depression, and substance use disorder. And suicide is now a very major concern, which accounts for 1%, 1.8% of all deaths, with the rate higher among men and the elderly. In terms of the policy and legislation, the Zimbabwean government has demonstrated modest support through policy development. We have the key policy, which is the Zimbabwean National Mental Health Policy 2019 to 2023, and its accompanying National Mental Health Strategic Plan, which outlines a vision for improving services. The policy emphasizes also the primary healthcare integration and the decentralization of services to the district level to improve access, especially in rural areas. And it also addresses equity for vulnerable populations. The governing law is the Mental Health Act, which is of the Act of 1996 with regulations from 1999. And the challenge that one that we have with this legislation is that it has not been revised since its enactment. And stakeholders report that it is now outdated. And while the Act stipulates free treatment at public institutions, and in practice, the patients have been required to pay since 2020. And though no one is turned away for inability to pay. And then if we look at the workforce that's available, we do have a critical shortage in terms of our workforce. So far, we have 18 psychiatrists, with most of them based in the capital city, Harare. We have 917 specialized psychiatric nurses and 6 psychologists. And this is from data that is from 2022. The economic instability has led to a brain drain, with trained professionals leaving the country or moving to other medical fields such as HIV care, which often has more funding from your international donors. And then if we look at your healthcare facilities that support the mental health care, the number of dedicated mental health facilities is also quite low for a population that has over 16 million individuals. In terms of inpatient facility, there's only 2 mental health hospitals, 2 psychiatric units in general hospitals, and 2 forensic units. In terms of outpatient facilities, we have just 7 hospital-based mental health outpatient facilities. And most of these facilities are urban, which leaves the rural majority unserved. And then if we look at the distribution of psychiatric medications, your essential psychiatric medications, including your antipsychotics, your antidepressants, and your mood stabilizers, are available at specialist and even primary care facilities. However, there are usually chronic shortages and unreliable supply chains, which then limit patient access. And those who can afford it may obtain those medicines through the private sector. And now, what are the frameworks that support the integration of pharmacists? So, what is the global mental health pharmacy practices, some of the foundational frameworks? Now, the international standard for pharmacy practice, as defined by the World Health Organization and the International Pharmaceutical Federation, establishes the pharmacist's role far beyond the traditional logistics of medication management. While the roles of preparation, obtaining, securing, distribution, and disposal of medical products remain foundational, especially in community and hospital pharmacy, the good pharmacy practice mandate emphasis to higher order functions, which is providing effective medication therapy management and actively contributing to the overall effectiveness of the healthcare system and public health. And this global directive is important for policy development in low resource settings as it validates the strategic necessity of then using pharmacists as integral clinical partners and not just your drug custodians. The emphasis on public health contribution, especially specifically positions then the pharmacist to address systemic issues such as access, adherence, and early detection in high burden areas like mental health. Now, effective intervention in mental health pharmacy begins with structure. And the World Health Organization's 4x4 framework gives us exactly that. It provides a structured approach to improving access to medicines by addressing four essential dimensions. You have selection, availability, affordability, and appropriate use. These frameworks were initially designed to ensure that medicines were chosen rationally, supplied reliably, priced affordably, and used correctly, and all underpinned by a very strong quality assurance and management systems. In recent years, the framework has evolved to fit the broader goal of universal health coverage, recognizing that access to medicines is not an isolated issue, but part of a complex health system. This systems approach helps us to see how pharmaceutical interventions influence and are influenced by every level of the health system. The framework is organized around four levels of action: the international, the national, the district, and the community levels, which then forms this 4x4 model that aligns 11 essential actions across these dimensions. And so, in practice, this means that in terms of selection, we are developing transparent medicine selection processes and educating our staff and the users. In terms of availability, we are regulating psychotropic medicine supply, we're ensuring quality and building community-based care systems. In terms of affordability, we are creating fair pricing and sustainable financing policies. And in terms of appropriate use, we are implementing evidence-based guidelines. We are monitoring prescribing and we are training healthcare staff in the rational use of psychotropic medicines. This framework then provides the foundation for reforming access to mental health medicines. And so then the clinical scope of pharmacists within this mental health settings is then broad and it's very important, particularly in resource constrained environments where the specialist input is rare. In psychiatric settings, we have clinical pharmacists who are necessary for assessing pharmacotherapeutic regimens to detect, to address drug-to-drug interactions, any duplications, contraindications, and to assess laboratory results as well. This assessment function is important for developing personalized treatment strategies. A major strategic advantage of incorporating pharmacists is their role in comprehensive medication therapy management and pharmacovigilance. In low resource settings such as Zimbabwe, where patients frequently grapple with severe mental illness alongside a high prevalence of infectious diseases such as HIV and AIDS, The pharmacist's medication therapy management function then takes on a dual life-saving purpose. So the pharmacist's expertise in your drug interactions ensures then the patient's safety, and it mitigates that high risk of adverse outcomes between your psychotropic medications and the antiretroviral therapy regimens. Furthermore, pharmacists serve as primary educators for pharmacists and their caregivers by providing clear, evidence-based advice on the proper use of the prescribed medications. This educational role extends to enhancing public health awareness, addressing stigma, and promoting early interventions. Pharmacist-led interventions focusing on education and monitoring have been shown to be effective in improving medication adherence. Emerging research supports the feasibility of pharmacist-led screening for conditions such as perinatal depression, anxiety, and general depression within the community pharmacy setting, which demonstrates an avenue for this early case identification. We also have the collaborative practice models and the integration of pharmacists into primary care. Now, the contribution of pharmacists into mental health care, although historically known, is increasingly formalized through your structured and collaborative frameworks. So, the collaborative practice models are necessary for managing patients with complex health needs whose care is delivered by multiple providers. And so it mitigates the risk of your fragmented and your uncoordinated care associated with very complex medication regimens. And so, if you have your pharmacists that are working side by side with your primary healthcare providers, this can empower and allow the pharmacist to prescribe or adjust medications under the primary healthcare provider's supervision. They can improve access to psychiatric medication management, and they can support even the primary healthcare providers in psychotropic prescribing. And so building that relationship is very important for a multidisciplinary team framework. And it also improves the comfort level of the primary care providers when prescribing certain psychotropic medications. In terms of barriers in the Zimbabwe framework, so Zimbabwe is an example of the constraints facing low resource settings in scaling up mental health pharmaceutical care. The barriers are primarily systemic, they are infrastructural, and they are economic. In terms of your systemic, operational, and infrastructural barriers, financial investment in mental health by national governments and international donors is globally inadequate to meet demand, which then leads to a shortage of mental health specialists. In Zimbabwe, the national priority list has historically been dominated, and rightfully so, by pressing matters such as food shortages and the HIV and AIDS epidemic, which then caused mental health to fall down the agenda. And when pharmacists were consulted regarding the provision of pharmaceutical care in mental health, the evidence suggests that the main constraint is a lack of systemic infrastructure rather than a lack of professional readiness. A study conducted in 2024 in Nigeria, which aimed to assess pharmacists' barriers, collaborations, attitudes, and perceptions, indicated that the single greatest barrier to providing pharmaceutical care to persons with mental illness was the lack of access to patients' records. And these infrastructural flaws far surpassed other reported barriers such as communication or language difficulties. This demonstrates that while specialized clinical training remains important, Immediate policy efforts should also focus on system strengthening. For example, the implementation of integrated digital or paper record systems that can facilitate a continuity of care and formalize information sharing, which is very important in multidisciplinary environments. And so, that multidisciplinary team has access to that patient's file and they're able to collaborate effectively. Furthermore, operational challenges are compounded by the stigma associated with mental health. The system's history, where requiring social work assessments to determine who qualified for free mental health care, created these systemic barriers and deepened stigma among already vulnerable groups. Another thing we have in terms of barrier is the human resource crisis. Over a period of many years, Zimbabwe has suffered a brain drain of health professionals, including your psychiatric nurses, doctors, and formal caregivers. This has had a negative impact on primary patient care, which has led to increased patient waiting times and heavy workloads for the remaining staff. High vacancy rates resulting in a blurring of professional roles, where the remaining nurses in rural areas are then forced to assume expanded responsibilities. So they take on the responsibility of the doctor, of the pharmacist, or even the physiotherapist, and so forth. This informal expansion of roles highlights a systemic breakdown. The emigration of specialists creates an unsafe reliance on non-specialists to perform complex pharmaceutical functions, which are often beyond their formal scope of training. Policy action can address this by formally empowering qualified pharmacists and pharmacy technicians to reclaim and secure the clinical domain of pharmaceutical care and to try and stabilize service quality and alleviate pressure on overburdened nursing staff. Um, Another obstacle to scaling community-based psychiatric services in sub-Saharan Africa is the challenge of ensuring a regular, adequate, safe, and affordable supply of appropriate medications. High medicine prices and the necessity for out-of-pocket payments hinder access for patients with extremely limited resources. The Essential Medicines List of Zimbabwe 2020 does include a range of psychotropic medications that cover both your older effective agents and the newer specialized agents. The policy clearly aims to support people with severe mental health disorders by including specialized medicines. But in practice, there's still a big gap as these medicines aren't always available or affordable. And so addressing the crisis in Zimbabwe requires translating some global best practices into adaptive strategies that are focused on human resource management and logistical innovation. The key approach is formalized task shifting coupled with supply chain resilience. Now, in terms of task shifting, task shifting or the rational redistribution of tasks to individuals within the healthcare team who may have fewer formal qualifications is a proven approach in global mental health that is designed to scale up services and address the severe shortage of mental health specialists in low resource settings. There is a strong evidence base for task shifting in managing other chronic conditions such as your hypertension and diabetes in low and middle income countries. So, by positioning mental health pharmaceutical care within the existing supported framework of your non communicable diseases management, greater systemic acceptance and funding likelihood can be achieved recognizing that mental health conditions account for a significant portion of years lived with disability globally. Pharmacists, as allied healthcare professionals, are well positioned to undertake expanded roles in primary healthcare setting by offering high quality care, independent prescribing where regulated, counseling, and education. These advanced roles include involvement in policy development as well, program management, early intervention and screening, and specific medication monitoring clinics where you have, your specialized drugs such as your clonazepam or lithium. Successful implementation of task shifting depends on several key elements, and that is training, a clear delineation of competency as supportive organizational system, and a legal framework that formalizes these expansion of roles. So without this legislative reform, which allows for formal collaborative practice agreements, um, the you may see an increase in pharmacist competency, but you would not, if it's not legitimized, then it may hinder any measurable impact or systemic integration. Another aspect is by strengthening the supply chain. Ensuring continuous access to your essential medicines is very important. It's an important component of community mental health services. This is to address the weaknesses in national medicine supply systems and to reduce dependence on out-of-pocket payments. Drug revolving funds offer a practical solution. These funds allow local health providers, such as your health clinics and pharmacists, to manage their own medicine supply by using the money earned from medicine sales to restock. This creates a self-sustaining cycle that helps ensure continuous access to essential psychotropic medicines. For DRFs to be successful and sustainable, they must be linked to a reliable financing stream that can subsidize the cost for the most impoverished patients who cannot afford even the inexpensive medications. Long-term financial stability must move beyond sole reliance on user fees and towards a more dedicated and stable revenue generation. Another very interesting strategy is by leveraging digital health and telepharmacy to expanded rural access. Given that mental health services are frequently centralized in urban centers in sub-Saharan Africa, and specialty care remains concentrated in major cities due to weak decentralization efforts, technology offers a powerful mitigating strategy. The use of telepsychiatry, as successfully utilized in South Africa, can be adapted to support telepharmacy services. So, telepharmacy allows pharmacists to provide expert consultation, medication therapy management, and supervision to nurses and community health workers in distant rural clinics where the brain drain has been most acutely felt. This expands the reach of scarce, qualified pharmaceutical expertise without needing any physical relocation. And it also overcomes geographical barriers and improves the quality of care that is delivered by the existing frontline staff. So, what does this mean for the pharmacy profession when we look at it in terms of our training and curricula? Well, the success of all the strategy also depends entirely on ensuring that the current and future pharmacy workforce then possesses the necessary competency, the confidence, and the professional identity to assume an expanded clinical role. Capacity building is then required at three levels by looking at the undergraduate curriculum with continuing professional development and mentorship and supervision frameworks in order to empower pharmacists as frontline mental health care providers. The foundational education for pharmacy undergraduates in low and middle income countries must be reviewed and expanded to match the broadening scope of practice. Traditional curricula often focuses on the primary uses of psychiatric drugs, the mechanism of action and the contraindications, the side effects. But it has become that inadequate. That is no longer enough. And so future pharmacists must also receive integrated training that includes the non-drug mental health care components such as basic counseling techniques, some psychosocial education, and effective coping strategies strategy development. Pharmacy students themselves recognize the importance of mental health care and express a strong desire to acquire the necessary confidence and skills to contribute effectively. And so, curriculum must also actively incorporate training on addressing mental health stigma, and which is a societal issue that crosscuts all aspects of care and contributes to professional discomfort in service delivery. So, providing opportunities for patients to learn from real patient experiences is also beneficial to then foster that person-centered care approach. In terms of continuing professional development and specialized training for the existing workforce, the pharmacy workforce is essential, the continuing professional development is essential to equip them with the skill set that is required to manage mental health crises and problems within their expanded scope. And while there are specialized postgraduate studies that currently exist, these must be scaled up, particularly for community pharmacists who are often the first point of contact. So, an example of an effective first step intervention is the implementation of programs such as the mental health first aid. So, this program provides practical training for managing mental health problems and crisis. Effective CPD implementation models that leverage peer coaching and streamline documentation processes can also maximize engagement. Lastly, we have the mentorship and supervision frameworks to support these expanded roles. So, in a task shifting environment, the specialist role then shifts from being a direct service provider to being a trainer and a supervisor or a consultant. For pharmacists operating under the collaborative practice agreements, a system of mentorship provided by senior pharmacists or psychiatrists is important to ensure patient safety and to build confidence in some of the complex psychotropic medication managements. Given the policy complexity in low resource settings, training should extend beyond just pure clinical practice. Pharmacists must be equipped with non-clinical skills related to policy development, program management, and the measurement of validated outcomes. This management and strategic competence is required to ensure that pharmacist-led mental health initiatives are not only clinically effective, but are also fiscally sound, strategically aligned, and also capable of securing future funding. And so finally, there are real life examples within Zimbabwe where the strategies can be implemented. The path forward for Zimbabwe requires integrating pharmaceutical care into some existing and successful community-based mental health structures and establishing a resilient financial mechanism. And so while I was doing my research, I came across a lot of innovative mental health services that are trying to reach, different demographics in their own way. And I saw that incorporating pharmacists within those existing structures is actually a good way to start, a first step to start. I came across this initiative called the Friendship Bench as well. So the friendship bench model, which was developed in Zimbabwe, is a globally recognized example of successful task sharing in mental health care. It utilizes trained lay health workers, known as grandmothers, to deliver culturally appropriate problem-solving therapy directly to the disadvantaged populations. This model is proven to be effective in reducing depressive symptoms and has scaled across Zimbabwe and beyond, demonstrating the efficacy of non-specialist interventions as well. The friendship bench model, which is typically integrated into local primary health clinics, provides the perfect pathway for the integration of pharmaceutical care. Many users of the friendship bench are living with comorbid conditions such as HIV, which requires careful medication management. And so, integrating the pharmacist into the friendship bench referral loop can act as a strategic force multiplier, and it ensures that scarce professional resources are used efficiently. The grandmothers would be handling the high volume of basic psychosocial interventions, while the pharmacist handles the complexity and safety surrounding pharmacotherapy. The pharmacist's proposed role can include things such as medication review and management therapy, medication therapy management, which is when the lay health worker refers a patient for potential pharmacotherapy, then the pharmacist can conduct a thorough medication therapy management review. They can manage adherence, some of the side effects, and particularly, more importantly, your drug interactions, especially if they have comorbid conditions or if they're on your antiretroviral treatment. Another role could be those who are more clinically advanced to offer specialized consultation, where the pharmacist would manage high-risk protocols such as your metabolic monitoring in primary healthcare settings for second-generation antipsychotics or therapeutic drug monitoring for those drugs with a narrow therapeutic index. Then this then fills the gap that is left by the immigration of your specialized psychiatric nurses and doctors. And lastly, a role can be played within the supply chain assurance. The pharmacist can act as the local steward of the drug revolving fund and can guarantee that essential psychotropics are continually available for the friendship and patients. So by formally integrating the pharmacist in this model, it ensures access to medication supports, the community-based, rights-affirming psychosocial care delivered by the grandmothers. And so to conclude, the evolving global landscape of mental health in pharmacy provides a powerful template for low and middle income countries like Zimbabwe to then reimagine the pharmacist's role in mental health care. These global models highlight a universal truth. Pharmacists, when empowered and well trained, significantly enhance patient outcomes in mental health care. Ultimately, the way forward lies in strategic integration, embedding pharmacists within existing community frameworks, strengthening education and policy, and ensuring continuous medication access through sustainable funding mechanisms. Then, by bridging global insights with local innovation, Zimbabwe can pioneer a scalable model of pharmacist-led, community-based mental health care that is contextually relevant and also globally exemplary. So that concludes the end of my session. Thank you so much for having me here, and thank you to Datus for hosting this session.